Prepare to experience the strongest radio allowable by law. Secrets will be revealed, myths dispelled. From the studio gym where excuses never apply, it's Superhuman Radio with your host, Carl Lenore.
Hey, welcome back to another episode of Superhuman Radio. Today is March 3rd, 2021. For those of you listening to the show 100 years from now, you realize that we really were way ahead of everybody else. We have a great show packed with great information today. A lot of people have type 2 diabetes today, and they're taking meds, and they think their meds are protecting them. And, you know, I get it. Use meds as a rescue mechanism, but the reality is that if you have type 2 diabetes and you're on medications for the next 30, 40 years, you're still going to get sick. The typical negative effects of having type 2 diabetes, heart disease, a higher risk of cancers, dementia, it just happens a little slower. But here's something your doctor's probably not talking to you about. And you're going to ask why. You can reverse type 2 diabetes in 99% of the cases today. And it doesn't take long, 6 months, 8 months. You could actually not have type 2 diabetes anymore. Imagine that. We're going to talk about that today. Then later in the show, I've been talking for at least the past 8 years that testosterone levels in men are dropping. If you look at the original assay numbers of what the limits were, it used to be 1,200 was the top end, 480 was the bottom end. Over the past 8 years, that's shifted downward. Now the top end is 900. The bottom end is 320. Very, very close to what some would consider the high end of women's testosterone levels. What's going on? And when men go through puberty with low testosterone levels, it may actually set them up for problems later on in life. We're going to talk about that a little bit later in the show. First, we have to thank our title sponsor, Legendary Foods. As the name implies, their foods are becoming legendary, especially their tasty pastry, which was originally designed to be an upgraded Pop-Tart, but it's become so much more than that now. The new tasty pastry is fluffy. It's kind of like the kind of crust you'd see in an apple turnover. 20 grams of high leucine, high quality protein, less than 5 grams of net carbs, less than 1 gram of sugar. Go to shrnetwork.biz/legendary, use the code SHR10. And get yourself some. If you're too cheap to buy them, I used to drink at a bar in Brooklyn called Tootie's. And Jackie Gleason bartended there when he was young. And Tootie, when he was an old man, most of us kids, we would sit there and we would nurse a 25-cent glass of beer. And Tootie would walk by and he'd go, spend a buck for crying out loud. Well, if you're too cheap to spend a buck, in the words of Tootie, you can win a box of tasty pastries if you listen for the secret word. It occurs during the commercial breaks. Once you hear it, email it to onair@superhumanradio.net, and you will be entered to win. We're giving away a lot. Just so you know, your odds of getting a box of tasty pastries is very, very good. So check it out. Okay. Without further delay, I'll bring my guest on and just get the imagery straight. And we are talking today with Dr. Frank Tortorice. How you doing, Dr. Frank?
Doing fine, Carl.
Welcome. So what I said at the beginning of the show, do you want to take an arm's length from that? My proposition that 99% of those with type 2 diabetes could reverse it if they understood how to?
I think there's a good amount of truth in that statement. I would say, as a practicing internist, I wouldn't put a number on it, but I would say, especially if we get people early. So if we get somebody before a formal diagnosis of diabetes type 2, the odds are even better. If they've had diabetes for less than a few years, odds in some cases, depending if they have comorbidities, is reasonably good. And then if they've had it for a number of years, probably a little bit more challenging, but not totally unreasonable. So again, we're talking about changing major lifestyle issues and using medicines in a supportive way. But I think it's definitely possible. We know stories of people that were on insulin, high doses of insulin, 40, 50 units multiple times a day, getting completely off of insulin in less than 3 months, sometimes in 6 weeks. That being said, if you're on insulin out there, don't do this on your own. It can be a little bit dangerous, but just to point out that that is a possibility. We see it, but under the care of a practicing endocrinologist or medical doctor or practitioner, I think it's highly likely. And that's kind of what we do here. We take people that have been on medication that come to me and say, you know what, I really like to see if there's a different way. And we kind of do it in a healthy manner. We don't simply pull them off all meds, that I think might not be the right way to go. But we gradually wean them off medications as their sugars allow. We recheck their blood sugars. We also go through a lot of lifestyle issues to make sure that what we're doing is a good fit for them. It's more important, like Paus said, to know the patient that has the disease and what disease the patient has. So we do it in a very personalized manner.
So over the years, I have done numerous shows about type 2 diabetes. And just to kind of summarize some of the messages we got from scientists who published papers. The first show that I did that was interesting was from a scientist from Rutgers University. And he had published a paper that showed that glucose signaling is what causes cellular senescence. This was probably 12, 13 years ago. So we're all talking about aging better. Well, can you actually age better if your blood sugar levels are all over the place?
So when the blood sugar is high, it's a very inflammatory process on the body. So a lot of people think that their blood glucose is a major determinant of inflammatory risk, but it's actually the insulin. It goes all over the place. Insulin, as you know, when you're young, you have a lot of insulin, you build up muscle, and it does a lot of things. When you're an adult and you're mature, having too much insulin around leads to a lot of different complications to many organs, the heart, the kidneys, the eyes, so on and so forth. So cellular senescence is brought on by a lot of different actions that happen in the body, and we're able to control the expression of genes. So epigenetics and other things to help with that process. That being said, we try to keep the blood sugar as stable as possible, because we know that when the blood sugars go up and down, a lot of bad things happen. The body gets overwhelmed, causes a stress response, and then a stress response, if it's maintained, prolonged, can be dangerous. Yes, we want small amounts of stress, but we don't want excessive, prolonged stress.
Okay, so with that being said, for some reason, can you lower my volume coming out of your computer just a little tiny bit? That's great. So with that being said, is it not a mistake for the medical orthodoxy to look at blood sugar and not look at insulin? Because just because my blood sugar is within the limits desired, my pancreas could be working overtime to keep it there. Why don't doctors look at, what is it, small peptide or C-peptide insulin along with blood sugar to say, wow, your blood sugar is great, but you're producing gobs and gobs of pro-inflammatory insulin to keep it there?
Right. So what had happened is my training in internal medicine, it was the blood sugar and the A1C. We never thought to look, okay, the endocrinologist maybe looked at insulin and C-peptide and fructosamine and maybe a 75-gram glucose challenge. But, when I started, we just didn't do that. We just didn't do that. So I think right now, because with my training in functional medicine, we're looking at root cause resolution and root cause analysis. So what we do is a lot of times we do extensive comprehensive labs, and I'll get blood sugars, right? And maybe on page 1 there's an A1C that looks really good, 5.2, but then I'll go to the insulin, it's like 30 or 40, and people want to have a fasting insulin depending on who you talk to. There's some debate, but at least less than 10. Some people would say 5, and other people would say 3, but certainly less than 10 is probably agreed upon. So what happens is the A1C is the last thing to go high. So if you've already have a high A1C, you've already missed the boat, so to speak. So we check our patients' insulin, and at times where it makes sense, we'll do a 75-gram oral glucose tolerance challenge. We'll check blood sugar, but at the same time, we'll check fasting insulin, 1, 2, and 3 hour insulin levels, because we want to see the response. All right. And we tell our patients it's not the blood sugar, it's the insulin. And like I mentioned before, as insulin being a pro-inflammatory mediator, we need to be really mindful of that when we're doing our testing. So patients come to me when either they have a family history. They say, my mom and dad had insulin. One was on, had diabetes. One was on insulin. I don't want to have that. I've gained a few pounds. I'm worried that maybe now I'm at risk. And then we'll go through the risk in a very personalized manner and come up. And you're right. You don't have to have diabetes. We tell people all the time, just because you're pre-diabetes, according to the numbers, an A1C between 5.7 and 6.4, it's kind of an arbitrary standard. You're suffering the same risk factors at 5.7. There's no free ride there. You're still having eye issues, and you're still having, possible early dementia, Alzheimer, kidney issues. So an ideal A1C, depending on who you're talking, will be 5.4. Some people say 5.2, but certainly 5.6 and 5.7 is associated with more negative outcome data. So early diagnosis and comprehensive diagnosis with your doctor or your health provider is very important.
Well, I would offer that A1C is now obsolete, and here's why I think that. And I'm asking you. I'm not. This is my opinion. So we assume that the red blood cell has a specific lifespan. I think it's 90 days, right? But wouldn't it be fair to assume also that people who are metabolically compromised, maybe their red blood cells don't last 90 days. Maybe they only last 45 days. And so that 5.5, if it was allowed to go out for 90 days, would maybe be 9.
Yeah. Yeah, that's correct. So the assumption is that the red blood cell life is a certain, like you said, 90 days. I mean, if you've had a transfusion or if you have iron deficiency anemia, you could be anemic. And I'll tell you, we have a certain amount of percentage of people that are anemic. And once they're anemic, that number no longer is valid. So right there, you have to really look at it with a grain of salt and make sure that you understand. So the A1C has to be interpreted properly under all those different circumstances. If they've had a red blood cell transfusion, well, then it's totally bogus. That's not even their blood that you're measuring. If they're anemic, then the percentage of cells that have lasted long enough to, have the glycated, particles on the hemoglobin is also probably not that accurate. So again, it's just one piece of the pie. I think, ideally, if the insurance allows, we love to do more with patients. And if they're at risk, I'll do it anyway and tell the patient, you know what, you need these tests for your health. I need to be sure that you're not developing diabetes, which you don't want to get. But yeah, we do a number of tests to check for diabetes. You're 100% right. The A1C is kind of, it's like the horse and buggy area because we need more. I mean, it's okay, but it's not, I wouldn't say it's the optimal way to check for that. We need to see what metabolic processes are driving blood sugar.
So early in the show, I mentioned, and I did this ominous message to people listening. So there's a lot of people out there I know people who have type 2 diabetes, but it's managed with drugs. Managed, dangerous word. It's managed with drugs. But the reality is that their bodies are sustaining all the same damage as frank type 2 diabetes, not managed. It's just slower. So with that being said, heart disease is said to be the #1 killer in America. Cancer, I think, is number 3. We have Alzheimer's disease and dementia occurring younger and younger. But the reality is all of those are offshoots of insulin resistance and type 2 diabetes. So really, if we wanted to be honest we could say type 2 diabetes is the #1 killer in America today. Am I blown out of my hat here?
No, you're exactly right. There's said to be 100 million people in America that don't know that they're pre-diabetic. 84% of them have no idea that they're on the road to becoming diabetic in 5 to 10 years. 100 million. So, we used to call it adult onset diabetes.
It's a third of the population.
Yeah, well, that's what we're looking at. So to say this is an epidemic is probably an understatement. Everything you're saying is true. So even in my classic training, having diabetes was considered an equivalent risk factor to having a heart attack in terms of managing cholesterol. So even traditional doctors would probably agree that diabetes is such a metabolic arrangement that many complications can come from that. But again, if you figure that 84% of the people don't even know they have prediabetes, when I see patients in the office and I tell them their blood sugars are high, a lot of times they say, "Oh, nobody ever told me that before. Nobody ever told me that before." And I said, "Well, we need to do something about this. We don't want you to have any issues." So, I find myself over and over. I had 3 patients in a row yesterday, and it was the same message. I should have recorded it and just laid it back to them. Everyone had the same thing. They had metabolic issues. They had weight gain. They had blood sugar imbalances. They had bad types of cholesterol. So you're 100% right when you say this is an epidemic. I see it every day in my practice. So we take it very seriously.
Well, and the other thing is blood pressure, right? We get this message about blood pressure. But I would argue that 80% at least of those with high blood pressure, it's a result of angiotensin converting enzyme, and that's tied to insulin production. You lower insulin and ACE goes down. You don't need an ACE inhibitor. So when you look at all of diseases today, metabolic syndrome, it's all a result of what I like to call acquired diabetes. I used to piss people off when I used to call it acquired diabetes. "Oh, you don't understand. My mother had it. My father had it. I have it." They want to blame it on genetics. And I used to say, no, you also learned how to eat from your mother and father. You didn't just get their genes. And the reality is that you have to work for decades to tank your pancreas. You have to work at it. You have to eat a certain way every day, every week, every month for years to give yourself type 2 diabetes. People don't like to hear that because they go, "Oh, I don't want to believe I gave this to myself." Why not? That means you can get rid of it too yourself.
Yeah, I mean, you're absolutely right. It's an acquired disease. I mean, there was, autoimmune disease or type 1, which is thought to be genetic, but now we're finding that it's not so simple to say one thing leads to another. Most of these are multifactorial. When you talk about metabolic syndrome, again, like you said, it has hypertension, hyperlipidemia, or high cholesterol, waist circumference in men or women, and blood sugar abnormalities. So it's recognized that, like you said, the blood pressure is part of the syndrome, and these are multiple inflammatory factors that we need to take under control. But again, we really try in our clinic to help patients feel good about the process of getting a chance to take control of their health. I think when I started, pretty much it was a top-down system where the doctor would say, "You're doing this now." Well, those years are gone. Now we have a dialogue with our patients, and especially in functional medicine, we have a collaboration. I mean, there's some things that people want to do, there's other things that people want to do. So we're able to talk with them, and we're able to be in a position to help them with something so important as their health.
I want to give your information here. Diabesitydoc.com, diabesity.doc.com, or email Dr. Tortorice at Dr. DOCTOR at drtortorice.com. If your doctor is not talking to you about this, if you go to your doctor and say, I want to get off the metformin, I want to learn to control my blood sugar naturally, I want to fix my body, and he gives you any kind of pushback, any kind of discouraging message, find another doctor. My parents, if the doctor said you jump on one leg for 2 hours, they did it. The doctor said so. Well, in all respect to current company here, doctors are just like mechanics. You could get a bad mechanic and he'll spend a lot of money doing nothing for you. And every doctor works within the confines of medicine differently. And you must find doctors that will work with you on your goal, but you have to have a goal first. You have to say, I don't want to be on these meds. I'm going to die sooner if I don't fix this problem. I want a doctor to help me fix this problem. That's a legitimate conversation for a patient to have today with a doctor, is it not?
Yes, it is. So again, it's hard to have a thick skin. I think, I've been on both ends of it. I mean, we try more successfully than not, but I can't say we have 100% batting average. But I tell patients that I work for them, and I think I'm in private practice. I can say that, but I think that what happens is a lot of times the doctor, over 50% of doctors are hired now. Way back when, just a generation ago, it was less than 30% of doctors. So the doctor doesn't work for you. He works for the company. The company says, you need to give this amount of money. You need to see these many patients, just churn them through. And the doctor, he has a mortgage, he has kids, maybe a wife, he's got a house payments. What's he going to do? Okay. The fact that the doctor gave, I don't want to really say anything negatively, but again, if you're not controlling your income, and somebody says, this is what you're going to do if you want to keep your job. You saw recently how many doctors were fired from certain facilities. So if you're a hired doctor, it's harder. But again, I would say, I want to preface this, most of the doctors I met, wherever they work, are some of the most fantastic doctors and human beings ever. Okay. So that being said, there may be doctors that aren't so great, but patients come to me and say, doctor, I was with my doctor. He gave me 3 minutes. He gave me a prescription. He said, talk to the nurse. And that was it. And I'm not sure that's enough now, because remember, years ago, penicillin was a cure for certain illnesses. Now, these are lifestyle issues. Americans die 75% of the time because of lifestyle issues. Mm-hmm. So if that's the case, you can't put somebody in and out. My nurse is always knocking on the door and say, doctor, you're late. You got the next, because I keep going with the patient. And it may not be the best financial model if I just keep in the room, but I got to get this information out to people. So with the Institute for Functional Medicine, they have a list of all functional certified doctors who understand this model, and you can go and find one right near where you live. Now, some take insurance, some don't. What the functional medicine doctors are doing now, because there was a backflow or a backlash saying it costs too much money, is they're doing what's called group lessons. The group lessons can be $50 or less. You meet other people with diabetes, you talk to them, you make friends, you go on the diets together. So we're trying to make it affordable for everybody. But that being said, is the patient, really, it's your life. You have to take control. If you love your doctor, stay with him. If you don't, then consider something else, because you only have one life. You really need to I can't stress this enough. You're the boss. You really are. And I work with people, and I wouldn't say I always make 100% of people happy, but I try my best. And sometimes they're just not a good fit, and we send them to somebody who's a better fit. But please take control of your health. Don't let what the doctor says hit you the wrong way. Don't do it. Don't do it.
Some of the problem is the people too, the patients, and we have to be honest here, right? We can't lay this all on doctors, right? Doctors, when they meet with patients, even those that are knowledgeable, are only as effective as patient compliance. And when we, I know someone personally who's had type 2 diabetes for the better part of 25 years. And I've had conversations with this person. And I said, you can't get up in the middle of the night and eat, cereal, which was a thing he used to do. And and he's on metformin, and he's on a bunch of other drugs. Obviously, he's on a blood pressure med. And I say to him all the time, let's make believe his name is John. I say, John, you can correct this. It'll take about a year, but you can correct it. And he has no interest, because it's too easy to keep eating crap and not sleeping well and taking a pill. And sometimes I think the pill mitigates the guilt of having a crappy lifestyle. It's like, well, I'm doing all this crappy stuff, but I take these pills and they're protecting me. And I want people to understand something loud and clear. They're not protecting you. If you're taking these drugs and you're still having episodes of postprandial blood sugar at 300 and above, and your fasting blood sugar in the morning is 125, you're broken. You're broken. You're going to get the cancer. You're going to get the dementia. You're going to have the heart disease. You're going to have it all. It may happen slower, but you're still not fixing the problem. And you know, I used to use an analogy early on. If you went to a mechanic and you said, "Hey, doc, my engine is making this loud clanking noise. You can hear it outside the car. Bang, 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 bang." And the mechanic said, I see the problem here. And he handed you a pair of earmuffs. And he said, "Put these on when you drive the car, because then you won't hear the problem, so it's gone." You would not take that advice and go, okay, and drive down the road, because you know that the car's going to blow up eventually. But that is what the medical orthodoxy does today with type 2 diabetes. Am I being too hard?
No, I think I've seen this time and time again. I think some of the failures that maybe I've had is it's not only about the medicines. And I think that's why now, we had the COVID, and that backed us up a lot because we were taking care of sick and dying patients. But we're organizing a team to have a nurse that's been trained in functional medicine and nutritionist, because a lot of times it's not about the meds. It's about what's going on inside, emotionally, spiritually. If you don't address that, you don't get compliance. Patients want to be healthy for the great majority. If they have depression can also be caused by diabetes and blood sugar roller coaster. So we really, again, try to see what is going on with the patient. And if they need more help, we have available, a registered nurse. We have available, a certified nutritionist. I was reading the book by Mark Hyman the other day, and he says about diabetes, he says, well, it'd be nice to cure diabetes, but I can't go into the supermarkets and do all these things, because he realizes that it's lifestyle issues.
Right.
So the metformin, we have many patients on metformin, and they'll come to me and say, well, doc, I've been taking this metformin for 10 years. What do you mean it's not working anymore? Again, that's the natural history of type 2 diabetes in the absence of other countermeasures. They'll have to go on. Now we're using injectables. But then you tell the patient, well, you're going on an injectable. And it's like, oh my God, I will never want to be injected. Remember way back when it was like insulin? Are you kidding me? But now they have a number of classes of agents that actually prevent or reduce the risk of heart disease. They have some fancy names, but yeah, exactly. So it's really important to listen to the patient, and I think having a team approach allows you to have the time. A lot of our patients need, there's 20% of the patients need 80% of the time, right? So again, we need to understand where they're coming from and come up with a game plan that works for them. Not every patient is going to be the same way. Each patient is different, but I would say that emotional and spiritual and just day by day stress affects diabetes. And if you don't address that, you can have them go away with 10 medicines. You're not going to get anywhere. We really have to understand this human being, what's inside them.
I want to answer this question, because I have to be honest. I don't know who you are, Ryan, but I want to thank you for commenting here. And this is an absurdity. No one can afford functional medicine care. $1,000 an hour. No one is worth that. No one. Who is charging $1,000 an hour? Anybody that you know? Do you know of any?
No, I don't know. I know that there's programs, and some of the high end. I think Ryan, there's a bit of truth in what Ryan is saying. Patients had like a concierge type model, and it was like, okay, you want to play ball, $5,000, and somebody's working hard, is paying for mortgage, is paying for school for the kids. It's probably not affordable. Again, I mentioned about group visits, and again, if you go to the IFN, Institute for Functional Medicine, you can find a group, a certified functional medicine doctor, and do a group visit. It may be as cheap as $50. Okay, I hear you, Ryan. I think $1,000 is absurd. That's an elitist.
My doctor is a concierge service. I pay $2,500 a year to have my doctor. I can call him. I can text him. A lot of stuff I don't get charged for. It's all under that umbrella. Now, when I go into an office visit, I do pay him. But compared to the $1,300 a month I pay for Anthem, Blue Cross Blue Shield, I feel like he's a bargain, because if he orders my labs, the labs he orders are extensive. The labs the average doctor is going to offer me, nothing at all. So I never knew anyone was charging $1,000 an hour out there. I mean, that sounds excessive to me. if anyone is.
It might be some of the very, very top. I don't know anybody at that price. And again, I was the first functional medicine doctor licensed in Burlingame, so I led some of the groups that like the podcasts and stuff like that. And we had some internationally known doctors on, and nobody was anywhere near that. So again, you can get a great doctor for a lot less than that. So I think the more important thing is to find what you need and to find the doctor that can help you at the price point that you're comfortable with. I don't think you should have to go into bankruptcy or take out a mortgage or a loan to see a doctor. That's unacceptable.
Well, here's the best part, and I'm going to kind of give away the ghost, and then we're going to go into a break. But a lot of this information is out there on the internet. Dietary changes that affect blood sugar, sleep affects blood sugar, improve the quality of your sleep, change your diet, get away from the high carbohydrate load diets, which tax the pancreas. I mean, a lot of this stuff is in the public domain right now. And now, obviously, you can't just, if you've been diabetic for a decade, you can't just go, well, that's fine, I'm just not going to eat carbs, because you're going to end up in hypoglycemic and passing out. But when you have to move in that direction, start to restrict the carbohydrates, start using carbohydrates that digest slower, using supplements like R-alpha lipoic acid, even apple cider vinegar reduces the carb load effect on blood sugar. But this stuff is out there for anyone who wants to read it too. Let's be honest.
Right. So I would say this, that there's some good things about Dr. Google, and there's some things that aren't so great. I mean, just as probably I couldn't read a manual and fly a commercial aircraft, same thing with diabetes. I mean, the order of things is important. You mentioned about the car. Well, you put the oil in, you put the gas in, and then you drive the car. If you try to drive the car without gas or oil, you're not going to get too far. So again, unless you're very experienced in this, you want to have somebody helping you with that. That being said, I think there's an affordable way to do that. So that's what I'd say to that.
We're going to take a quick commercial break. And when we come back, we have more. Please keep posting comments and questions. We'll work them into. Pure Nootropics is now carrying the antioxidant alpha lipoic acid in its bioidentical natural form as R-Alla. R-Alla provides protection in many areas and has even been shown to promote weight loss. Check out the interview I did on episode 2608 back in October to learn more. Our friends at Pure Nootropics have been bringing you great products and deals since 2013, and they have another one with R-Alla. Go to shrnetwork.biz/pure and use code SHR30 for a whopping 30% off. Level up. Go Pure.
New Mass Pro Synthogen X2 just upped its own legendary game. To distance itself even further from the rest of the pack, Synthogen X2 now has double the key active ingredients. If you've ever wondered what steroid-like recovery feels like, Synthogen X2 delivers. See why others compare it favorably to powerful bodybuilding drugs at synthogen.com. Mass Pro Synthogen. When you train with it, you'll gain with it.
Meteor. TaylorMade Health is focused on making sure you're able to perform and look your best. They are a leader in game-changing supplements and cosmetic products. Whether you want to increase strength, expedite recovery, facilitate soft tissue repair, or reduce deep wrinkles, TaylorMade Health has you covered. TaylorMade Health is also the home to Dr. Seed's products such as BPC, BPC Plus, and the Chill Pill. All of my listeners can now get 20% off their first order with code TRY20. That's TRY20. This code can even be used on subscription orders. Visit shrnetwork.biz/try20 today and use code TRY20 for 20% off your first order.
This is the Superhuman Channel, doing reps with the weight of the world.
Hey, welcome back. You can't talk about recovery without talking about adjusting the nervous system. And one of the best times to do that is right after you train and after you've eaten your post-workout meal. I found the product called NuCalm. I put on my little visors. I listen to the app. It uses binaural beats, and it relaxes me. I use it post-workout. This is one of the best tools I've ever found, because I believe the rest and digest edict that comes from evolution is very, very important. Now, if you're metabolically challenged, getting up and moving around post meal will help you balance blood sugar. But if you're a healthy person and you trained intensely, cortisol is raising, you eat your meal, you put on your Nucom earbuds and your eye covers, and you run the app, and it will relax you. See, I would love to be able to just take a nap, but I can't. I got to come to work. So I do this at my desk once I train and once I eat, and I sit down. Nucom helps you recover faster. It's a simple way to do it. I'll tell you another application is using it before bed. I get a lot of people who say, oh, I can't fall asleep at night. My mind is racing. I can't fall asleep at night. This is this will solve your problem. It's been clinically proven to work in over 1 million sessions. It helps you sleep. It reduces stress. It boosts recovery without drugs or side effects. It's a great investment. Right now, my audience can go to shrnucom.com and you can actually save 50% off of your first 30-day subscription. Go to shrnucalm.com and get 50% off your first 30-day subscription. Check it out. You'll love it. I use it every day after I train and after I have my post-workout meal. And I believe personally, this is the best use of this device. So check that out. All right, getting back to the topic at hand. We're talking with Dr. Frank Tortorice today. We're talking about fixing your type 2 diabetes. I think a lot of people don't understand that they can fix their type 2 diabetes. It's not discussed, but the reality is that most of the people who suffer from type 2 diabetes gave it to themselves, and as a result, they can get rid of it. The question that comes up now is about diet for a second. There are dietary recommendations for type 2 diabetics. The American Dietetic Association has a book for people with diabetes. The book has nothing but carbohydrate foods. Isn't that a mistake? When you have somebody who can't manage blood sugar, do you really want to constantly be raising blood sugar?
No. Yes. Yeah, I understand. I've seen those same documents, and we've had those referrals. I've talked to the dietitians, and basically that's what they've been trained. Now, again, in our practice, we use a functionally trained nutritionist, either with the IFM or one of the other certified institutes. A lot of our patients can handle carbohydrates, and carbohydrates are the foods generally which cause a higher raise of insulin. So if they already have a problem with insulin and insulin resistance, then what happens? And they have to keep secreting more and more insulin to eventually the pancreas is no longer able to handle that. And then they can have diabetes from that. So a lot of our patients are on a lower carb diet, but then, as you know, if you were just on protein only, and then you kept on for extended time, you'd actually become more insulin resistant. So again, we like a monitored, measured approach. Everything is in moderation. We don't believe necessarily in going one end or the other end. We have vegetarians, we have vegans in our practice. We try to accommodate their choices, but we try to give them good alternatives, and we try to educate them so they can make better food choices. So I think that's part of it. I think you have to come to people where they are. I think to say you have to have only protein or only carbohydrate or only beans, I think first of all, people don't want to do it. You have to come to them where they want to be. But if they're making choices and not preparing the foods properly, then they are going to get into trouble, and eventually they're going to make it worse.
So a more athletic population will tell you that they'll eat between 1.5 and 2 grams of protein per pound of body weight. And there's a group of people out there who say, well, rapid absorbing proteins like whey protein will just spike blood sugar. However, I've done shows with scientists that will tell you that gluconeogenesis is a very, very metabolically expensive process. It doesn't happen willy-nilly. The body has to really be losing blood sugar quickly in order for it to turn on gluconeogenesis, which would mean that maybe protein doesn't really just spike blood sugar. What do you think about the protein conundrum?
So excess protein does probably spike in certain instances. It depends on, again, what it's with. Again, if you have a lot of fat in there, it slows down absorption. But if you're a bodybuilder or physically active to a high degree, then probably you need the higher amounts of protein. Most people can do well with maybe even half a gram of protein. They're not physically active. What happens is when you over consume, the body's able to maybe assimilate 25 grams of protein. So if you have, a super human-sized steak, you're not going to be able to assimilate all that. Some of that will go to waste or go to fat. The body says can't turn this into energy right now. We either got to eliminate it, burn it off, or we got to store it. So making sure that I think they say a palm-sized amount of protein 3 times a day is a good approach. It's not super technical, but your palm is going to be there with you. So, it's about 20 grams, 25 grams, 3 times a day is all you need. Again, if you're a professional athlete or something like that, then maybe you can go to a gram or gram and a half. But most people, the majority, will not be anywhere near that. And then again, if you're in diabetes, you've had diabetes for years, your kidneys do get damaged. You give a load to the kidneys, and it could cause some issues. So again, you have to individualize it, but that's a good basic number.
Yeah, no, I agree. I know that a lot of people in our audience are eating higher protein. I do know that, and I do. I mean, I eat 250 grams of protein a day, but again, I train and I'm trying to maintain and build muscle at an advanced age too. And I know that I need that extra mTOR flip to get there. But then I do combine that with time restricted feeding. After 6 p.m., I don't eat again until the next morning. So I'm allowing mTOR to shut down, autophagy to occur, and I'm honoring the evolutionary edicts that my body has developed under. So what do you think the number one mistake, or let's say top 3 mistakes people make when they're looking at addressing and reversing their own type 2 diabetes?
So again, most people, if they develop diabetes because of lifestyle issues, either they've learned things which aren't benefiting them, or things have changed. Maybe they had a death in the family, or maybe they've gone through financial. With COVID, we've seen a lot of people gain weight. So again, people, everyone's limited in knowledge, right? And then there's a lot of advertising that maybe not as accurate as it could be. And, oatmeal, a lot of people can't handle oatmeal, and it turns them into a diabetic. So that's not true for everybody. There's some people that have a gene, they can handle more carbohydrates, but a lot of people, any type of oatmeal is like taking pure sugar. So again, you have to know yourself. So we don't restrict anything, but again, if in this person we find a certain lifestyle issues are a problem, we point that out, and then they can make that change. The restricted eating, as you know, is very good as well. I mean that's been shown for longevity. The mouse studies where they even fed mouse bad stuff like sugar and stuff, but as long as they're restricted, they still lost weight and were more metabolically active, as opposed to the mouse that ate so-called healthy mouse food, but ate it through the 24-hour cycle, actually did worse. So there's a lot of little hacks we're learning out there, and I think it's important. We have patients that work the graveyard shift, and that's not necessarily great for their biorhythms and hormones. So at a certain age, we tell them, if you need to work these hours, you may experience some bad health effects. If you're 20, it's still not great, but you're 20. If you're 50 or 60 and you're doing this, and you're really adding an extra stress to your body. And then the worst is when you do morning one day or 1 week, and then evenings the other week. So it's not as bad if you're doing graveyard and that's all you're doing. But if you're going back and forth from the different shifts, that's probably the most dangerous of all.
I bet you if someone took the time to look at how long ago we started to have round-the-clock television shows, because when I was a kid, most stations went off the air at midnight, 12:30, and they just had the test pattern all night long. And then they started to play into the morning hours, maybe in the 70s, I want to say, around the 70s, late 70s, early 80s. And then we had cable, and then we had TV round the clock. I would love to see an analysis of the occurrence of type 2 diabetes and as it correlates with nighttime television watching. I'm willing to bet that as nighttime television watching went up, blood sugar management became a problem, because we know. I did a show probably in 2007 with a fellow who worked with Olympic athletes. When we had the Winter Olympics out on the Northwest, he worked with some of the athletes, and they short slept them one night. Now, these are athletes, metabolically perfect, and they got less than 5 hours of sleep in one night. The next day, they had the metabolic dysregulation of an 80-year-old. That's what the study said. They had trouble managing blood sugar. That was one night in a human being that is ideally functioning. So what do you think it does when you stay up and watch Jimmy Kimmel and you snack a little bit and you do that night after night after night? Don't you think that the modernity, technology has contributed or is contributing to the problems we see with the metabolic dysfunction today?
Yeah, there's no question lifestyle issues. Like you said, one night of poor sleep causes insulin resistance. I mean, people now have glucose tracking monitors and they're seeing this. We have people that are, like biohackers and things, and then they notice when they miss a night of sleep, the sugars are all over the place. The one study I'm aware of from the 60s and 70s is when they started to introduce low sugar and low fat, higher carb meals, that the percentage of diabetes went up from about 10% to now it's over 30%, and also the weight gain went up. So that's a pretty proven fact, is when they decrease the fats in the food, or the healthy fats, and they added more carbohydrates. But yeah, I'm aware of the study with the soldiers. It was, a lot of these people, you got to remember, were like 20, 22 years of age. They were in excellent shape, and they looked like 80-year-old guys after just a night or two. It's pretty eye-opening, because sleep is something that's non-negotiable. Okay, and again, that's a lifestyle issue. So if we have a diabetic and they're taking their metformin, but they're getting 3 hours of sleep, and we have patients that get only 3 hours sleep per night, they don't do well. They do poorly. And again, one of the problems with blood sugars can be caused in part by sleep apnea. How many people know they have sleep apnea? Sleep apnea is also on the rise. A lot of people say, well, Doc, my BMI is great. I'm skinny. Why do you tell me I have sleep apnea? As you age, the bones of the respiratory tract in the mouth and the throat, they undergo some changes as well. And at 20 years old, you had good open airways. As you get older, then the change in bones causes you to have some sleep apnea.
I would respectfully suggest that we have gut dysbioses. We have you can see people that are relatively lean, they have distended stomachs. You see people that they look pregnant. This is an indicator, if not visceral fat, inflammation. And that inflammation, in my humble opinion, travels north. It goes up the esophagus. It starts to affect the esophageal sphincter. They have silent GERD is all the rage today. There's a swelling that occurs. The airway starts to narrow. You have children snoring today, and it's linked to ADHD. They say I did a show about it. If your child snores, don't laugh at it. Oh, he snores like a little truck driver. He's not getting good sleep. And then the next day in school, he's fidgety and he's all over the place and he's getting spanked and all that. So there's an inflammatory process occurring in the gut that's traveling north. And I believe that has more to do than the changing palate, because I know I did that study too, where they have to actually break some kids' upper airway and open those bones up so they stop snoring. But in most adults, you see them, they have distended stomachs. They have big bulging stomachs. That's inflammation, and it's going north too. We have to take a break. Hold on a second. I want to plug your website again. So if you are interested in working with the Tortorice, you can go to Diabesity, DIABESITY.com, or email him at Dr. DOCTOR at DRTORTORICE.com. One of the good things that happened with COVID is telemedicine. So I'm sure that that's been good for you too, because people from New York and other states can reach out to you now, correct?
So the COVID restriction was a temporary restriction. So we've applied for licenses in certain states. Certain states say it's okay, but we have to have a license. Other states, they still have a waiver. So we have a manual that has like 50 pages. It has every state and up to date what the restrictions are. So whereas I can work with some states, Other states, I can't provide medical care because even at telehealth, they don't consider me a licensed doctor. So we've made an application in Florida, for example, and there's a couple other states that showed interest. So California is not a problem, but each state is individual. So you know, if they want a license, even for telehealth, and we go through the paperwork, we get the license.
When we come back, I want to talk about an unidentified culprit that I think is interesting, and I want to find out if you've been keeping this on your radar too. And then later in the show, we're going to talk about testosterone levels during puberty in young boys and how that may affect problems later on in life. Oh, and one other thing, we're announcing the first winner of our Milestone Meteor. We're giving away 5, and we have our first winner. One a week will be announced on every show going forward, and we're going to announce the winner of that. Lots of exciting things happening here. Stay tuned. We will be right back. Getting a massage post-workout is a proven strategy to facilitate better recovery. Getting to a massage therapist can be difficult and expensive, especially in these times. The solution is the Meteor, a heated massage ball from Milestone. Reduce pain and soreness and expedite recovery with the Meteor's research-backed vibration settings and therapeutic heat. It's convenient for travel and works on any body part. Go to shrnetwork.biz/Meteor and use code SHR15 for 15% off and free shipping if you buy 2 or more. Start recovering better today. Whether your goal is to build muscle or burn fat, you'll find everything you need at Redcon One. Need help getting a good night's sleep? Try Fade Out, or the most popular pre-workout supplement on the market today, Total War. Sign up for their new Transformation Challenge and win $10,000, or shop for apparel that people at the gym will know that you are serious about your training. Need a testosterone booster that works? Check out Boomstick. Whatever you need, you'll find the best quality supplements on the market at Redcon One. Go to redcon1.com. That's REDCON, the number 1.com, or go to superhumanradio.net and click the Redcon One banner ad today. Meteor P3OM uses a patented natural process to upgrade a well-researched probiotic strain that doubles every 20 minutes once inside your body. The patent proves this strain is proteolytic, meaning it digests protein. It's antiviral, antiretroviral. It eliminates pathogens and waste and is maintainable in the human digestive system. What it does better than any other strain is fight the bad guys, bugs like parasites, viruses, and other pathogens in your gut, and it doesn't require refrigeration. If you suffer from bloating, gas, indigestion, or you just need extra protection from viruses, aka bad bacteria, then I'd suggest trying this super single strain probiotic proven to wipe out bad bacteria. Go to bioptimizers.com/SHR to get a 10% discount coupon with code SHR10 and free shipping on all products. Or save even bigger by signing up to one of the plans to get as much as 38% off. That's bioptimizers.com/SHR. Do you remember those delicious toaster pastries you had when you were a kid? You know, the rectangular sugar-filled snacks? Well, guess what? Legendary Foods has just made low-carb toaster pastry. This is the first of its kind, and honestly, these things are amazing. They have 3 to 4 net carb, less than 1 gram of sugar, and 9 grams of protein. You can eat them right out of the wrapper or lightly toast them. The only question is, which flavor, strawberry or brown sugar cinnamon? They're available at eatlegendary.com and Amazon.
This is the Superhuman Channel. Evolution just got kicked up a notch.
Welcome back. So before we wrap up the interview, I want to go ahead and do this right now. We have our first winner of the Meteor, which is a massage ball that I love. I carry it around with me. It's actually in my car. I put it in my lumbar area while I'm driving. And that is Stephen Rushing. Stephen Rushing won the first one. He'll be getting his Meteor very shortly. We're excited for him. The next winner will be announced and selected next Wednesday. So how do you enter? Go to shrnetwork.biz/free Meteor, FREEMETEOR, and enter. There's still plenty of room to win one of the other 4. Don't hesitate, because I'm telling you, a lot of people are signing up. There you go. Congratulations, Stephen Rushing. Back to Dr. Tortorice. So I've been reading a lot about Pde5 inhibitors because the anti-aging community is now attracted to them. There's a lot of people that are prescribing 5 to 8 milligrams a day of one that kind of accumulates, has a longer life trajectory, and that is tadalafil. But what I've learned, however, is that Pde5 inhibitors increase insulin production. They can actually increase insulin production in the absence of carbohydrate consumption. So any thoughts on that? Have you seen some of this research that it may cause insulin to spike even when insulin isn't needed in the bloodstream, which also means it could precipitate some hypoglycemic episodes with people who are already sensitive and not metabolically flexible?
Yeah, I think I saw one study, but I can't say that I've got a total picture on that yet. I know that the nitric oxide pathway is important for a lot of different reactions, and I know it has to do with endovascular health and some other issues. But actually, again, since I've only seen the one study, I reserve to give you a final answer. But I am aware of the nitric oxide inhibitors and the different formulations.
So this is a great question, and I'm glad Robert Thompson asked it. In your opinion, are there any downsides to metformin? It is now being adopted and has been by the anti-aging community. I've been a staunch opponent of metformin for anti-aging, and now people like Dr. Peter Attia and even Dr. Mikhail Blagascloni are saying that unless you're already metabolically challenged, it provides no benefit. What about you? What do you think?
Well, I mean, again, if you're a diagnosed diabetic, we initially use it because it helped with the liver and blood sugar, and also patients would lose maybe 3 pounds. It wasn't like they'd lose 20 pounds. But again, you got to remember that long term, you're looking at B12 deficiency, vitamin D deficiency, and a lot of other things that we see in our diabetics. So as an adjunct, again, I think if you're doing all the basics right, so you're sleeping, you're eating properly, you're getting stress management.
Time restricted
life extension was, but I thought there was a study also about cancer possibly. So yes, I think the jury's still out a little bit on this. So before we would give it to a healthy person, we'd really be careful with that.
Breast cancer has been associated with women using metformin. And I know a doctor whose wife is in her 30s, and he's had her on metformin for, I'm not going to mention his name, but he's had her on metformin for 5, 6, 7 years as an anti-aging, and she was just diagnosed with breast cancer. And I wonder sometimes if he's thinking to himself, maybe she wouldn't have got it. Look, time-restricted feeding, increasing metabolic flexibility, these are all endpoints of managing your type 2 diabetes and fixing it. And we know that people who are metabolically flexible, who eat, for 16 hours fast for 16 hours, eat for 8, regardless of whether you start in the morning, start in the evening, but it's better to be done eating earlier because Dr. Dale Bredesen shows that actually can contribute to resolving dementia. If you look at these things, you can achieve all these things without berberine, without metformin. You don't need, when you take a drug so you can be lazy, it's a mistake. It's a mistake. That's my humble opinion. Am I being too harsh?
No. Again, they call them supplements for a reason. They're supplemental to, like you said, sleep, eat, stress reduction. As you alluded to before with the SIBO or the gut issues, a lot of diabetic issues are exacerbated by either small intestinal bacterial overgrowth or infections, and then you have GERD and other things, and this can also cause inflammation, and that can also contribute to diabetes. So I'm aware of Dr. Bredesen's studies since I'm part of the RECODE 2 profile. We have a lot of patients that are elderly and unfortunately are suffering from either Alzheimer's or frontal temporal dementia or Parkinson dementia or vascular dementia. So we've had a lot of requests to help with that. And I know that Bredesen's Institute has that program, and I'm currently enrolled in the RECODE 2 program. So I'm aware of his work. It's very scientific, and there's a lot of things out there. And again, as we mentioned, Alzheimer's too, it's also related to diabetes. Since you have a leaky brain, we have a leaky brain, you have inflammation. you don't make good connections, and then you lose some of your mental faculty.
Oh, depression is tied to inflammation. We did shows years ago where studies showed that inflammation occurs in the brain along with the rest of the body, and it leads to depression. Major depressive disorder has been tied to inflammation. You know, it really is. It's sad, but it's exciting to me, because the sad part is not enough people have this information available. And obviously, the new evolutionary selection pressure is where you get your information from. And if you're listening to people who are saying, hey, popcorn's a great snack before bed because it'll help you sleep longer. No, you're metabolically inflexible. You need glucose throughout the night. You're waking up because your body wants food because glucose is dropping. The right thing to do is fix the problem, not eat popcorn before you get into bed. So it's sad, because there is good information out there. How do you find it? Listen to Superhuman Radio, because we have doctors like Dr. Tortorice on that can help you navigate your type 2 diabetes. Diabesity Doc, DIABESITYDOC.com, or email him at doctor@drtorice.com. We'll have him back on the show. Thanks for being here today, brother.
Thank you so much. It was really an honor.
And we will do it again, I promise you. We're going to take one quick commercial break. When we come back, we're going to talk about young boys and puberty. And this is really something that I'm excited to talk about, because it's something that we have alluded to for years on this show. And it's finally, the hens are coming home to roost. Stay tuned. We'll be right back. The power of light can be truly life-changing and an important element for every superhuman. Because of this, I want you to experience the power of award-winning Celluma light therapy. Celluma utilizes NASA research technology to improve health at the cellular level and is cleared by the FDA to effectively treat a variety of pain, muscle and joint conditions, as well as facial wrinkles and acne. Our entire team here at Superhuman Radio uses it. Its innovative shape-taking design allows for easy placement anywhere on the body. Choose from 13 different models. For an exclusive listener discount, go to shrnetwork.biz/Celluma. That's CELLUMA. And use code SHR10 to save 10% off of one of these award-winning devices.
New Mass Pro Synthogen X2 just upped its own legendary game. To distance itself even further from the rest of the pack, Synthogen X2 now has double the key active ingredients. If you've ever wondered what steroid-like recovery feels like, Synthogen X2 delivers. See why others compare it favorably to powerful bodybuilding drugs at synthogen.com. Mass Pro Synthogen. When you train with it, you'll gain with it.
Are you ready to change the way you age? Of course you are. That's why you're here. Juvicel is a new first-of-its-kind dietary supplement that includes 10 key research-backed ingredients shown in studies to support lifespan. Things like resveratrol, fisetin, quercetin, pterostilbene, sulforaphane, turmeric, all in a single dose. You may have some of these ingredients already, but Juvicel is the first to combine them all into a single product to support your lifespan. It's vegan, non-GMO, and sustainable. Live better longer with Juvicel. Go to shrnetwork.biz/live better. Use code SHR and save 20% off today.
You're listening to the Superhuman Channel. We're ripped and we're ready.
Welcome back. Welcome back. We're joined now by Dr. Tomas. Is it pronounced Paus?
Paus.
Paus, thank you. Dr. Tomas Paus, welcome to the show. Your study recently was published. I find it fascinating. It's actually something we've talked about over the past 15 years. We're seeing a drop in testosterone levels in men, especially in the United States, I would say in North America specifically. And it's been scary to me. And you just recently published a study that looked at low testosterone during puberty and how it may sensitize the brain in adulthood. Talk about why did you do this study? What work preceded this that you felt this research needed to be elucidated?
First of all, thanks, Carl, for having me on your broadcast. I've been interested in adolescents for the past 20 years. I studied the adolescent brain. I'm a neuroscientist, not a physician. So your listeners should not expect any individual advice from me. It's just curiosity and interest in how things work up here in our brains. So obviously, and if you are interested in the adolescent brain, you have to take into account puberty and sex hormones. That's one thing. Of course, you need to take into account also social environment, our peers, sexual maturation, looking for mates, and all this stuff. So that's how we started more than 10 years or so ago, with setting up different cohorts, scanning the brains, getting information about this and that, and we've learned quite a bit about how testosterone shapes the adolescent brain, in particular in males. And this study is one of quite a few that we published.
So over the years, I have asserted, without any real evidence, and so I'm going to ask you now to correct me, that when we look at neuroses, schizophrenia, manic bipolar disorder, they seem to start at puberty. You have a relatively normal child, and then as they go through puberty, you see manifestations. And first of all, am I correct on that assertion?
Certainly for schizophrenia, and in fact, one of the motivations for us to start the cohort, a different cohort, not the one that we are talking about, is the observation that schizophrenia begins to manifest by about 4 or 5 years earlier in young men as compared with young women. So clearly, puberty, in particular male puberty, has something to do with the onset of schizophrenia. I don't know about bipolar, but for schizophrenia, I'm certain. And you may know that the most popular theories of schizophrenia is so-called two-hit hypothesis, that you have a very early hit, something happens even before we are born to brain development, making it a little bit more vulnerable, and then something else happens potentially during adolescence. And when you have those two hits, you are at much higher likelihood of developing severe mental illness, including schizophrenia. Now, of course, adolescents can provide lots of different sources of that second hit. Very often we talk today about cannabis, weed, right? And we know that that is a risk factor. And of course, we know that substance use begins during adolescence.
Right.
The other one is sex hormones. And then the third one is, of course, social stress. I don't know whether you remember your high school years, but they can be stressful, partly because of our peers, right?
I mean, I did a lot of self-medicating in high school. I did a lot of LSD and smoking pot and all that other stuff. So I agree.
Well, you came out well.
Yeah, luckily. Well, the jury's still out. We may find out something. But so has anyone done any research to either introduce, let's say, androgens or do androgen blockades and see if schizophrenia changes its trajectory?
No, not as far as I know. They are, in fact, funny that you asked that question. I'm writing a chapter on adolescence and psychosis, and I was just looking into literature on the relationship between testosterone and first episode psychosis or schizophrenia, and just doing it yesterday and today. And there are few studies that show correlations, but no causality. And mostly, in fact, low testosterone, as far as I could see from those few papers, and higher risk of psychosis later on. But those manipulations are rarely done in humans. There is a lot of literature, of course, in animal models, and there you can see something along those lines of what you said. But then, of course, it's not schizophrenia; it's behavior in mice that resembles certain behavior of patients with schizophrenia. But that's a long shot, of course.
So talk about your research. What were you looking for, and what did you discover?
Right. Well, we were really lucky. As I told you, we've done a lot of work on puberty and testosterone during adolescence, but I wanted to know whether there are any long-term consequences, if you like, so going beyond puberty. And I was able to collect data in a birth cohort. So that's a cohort, in this case, based in England, where about 10,000 kids or 10,000 mothers were asked to participate in research before even those kids were born. And then they visited the center over and over, including during their puberty. And at several time points, they took blood samples, and I was able to look at those blood samples, measure testosterone levels between the age of, say, 10 and 17 in about 500 of them. And then at about the age of 20, we put those young men, in this case only men, we put them in the scanner and asked them to look at faces, at video clips of faces, as they were either angry faces or ambiguous faces. And we asked whether their history of pubertal testosterone has anything to do with how their brains responded to the faces. Now, you may ask, why faces? Well, that's an obvious choice in the context of social cognition, because of course face, and that's why we are looking at each other here and not just listening to each other. You can read my face, I can read yours if I zoom in a little bit, and we can identify each other, we can identify emotions. We can even, you can see that I'm now looking out the window. Most likely you don't see the window, but I'm not looking into the camera. So we can get a lot of information from a face. That's why we use the face. And then we discovered that in fact, it's not only that the pubertal levels matter, but they matter in a particular way. They matter in combination with the current levels of testosterone. So it ended up, the story is very complicated one, that whatever happened during puberty with testosterone left a trace, if you like, in your brain that then influenced what my level of testosterone at this moment is doing with my brain. So the kids who had low testosterone during puberty, in fact, their current level of testosterone influenced much more strongly brain response to those faces.
Okay, now did they in fact have lower, were they in like the lower quartile of adult testosterone, just out of curiosity, since they had low, low testosterone during puberty?
Right. Well, no, that is relative. All we do is we take our 500 kids, at the time of puberty, and we just rank order them. So it's not relative to the adult testosterone. It's relative to all the other kids from that age.
Okay, what about the first hit? What about when you looked at the mother's blood levels? Did you see any kind of indication, oh, well, the mother had a high testosterone level and now it's anything like that?
Well, that's $1 million question. Of course, we don't have access to these data, because what you would need to do, and that's really the important issue of so-called organizational effect of testosterone before we are born. We know that it exists, but in order to answer your question, it's not enough to get plasma levels of testosterone in the mother. I would need to get testosterone levels from amniotic fluid, right? And that you cannot do, of course, without clinical reason. So we don't know.
So there is research. I tried to get the scientists on my show 6 or 7 years ago out of Scandinavia that looks at sexual preference. And they did it in rodents, and there were 3 studies. It was 2 scientists, 3 studies they did. And basically what they did, in simplification, is they understood that the genitalia starts to form in the first trimester, but the brain and sexual preference occurs in the 3rd trimester. So they influenced the fetuses by giving the mothers either an androgen or an estrogen during the first trimester, and then using a different androgen or estrogen in the 3rd trimester. And they successfully created what we would call homosexual rodents. They have rodents that have male genitalia that prefer males sexually. So we understand that this first hit is fascinating to me, because it may play a larger role in the setup, so to speak, of how the brain reacts to sex hormones. So it would be fascinating to know what the first hit was when these babies were being formed, to see if you can actually make a schizophrenic model. Oh, look, when we did this and this is what happened. Any plans on experimenting like that?
No, I don't do animal work, so I can't experiment, and I can't experiment with humans. But let me come to your question and that particular experiment. So what you just described is, of course, an extreme extreme manipulation of hormone levels before we are born. And as I just said before, yes, there are, of course, variations in the exposure to testosterone in utero before we are born in males, right? In fact, we know that in twins, if you are a female and you have a co-twin brother, you are exposed to slightly higher levels of testosterone than if you are your co-twin is a sister.
Interesting.
And we did show that, in fact, there is a slight difference depending on this. In fact, even how your face looks like. That you have more feminine face, in double quotes, if you were there with the sister as a woman, as compared with being in there with your brother.
Right.
So there is a slight continuum there. And I think it's very important to realize that even you were talking about sexual preferences, but we've done now more recently work on looking at sex as a continuum, not as a binary variable. It's not about being male or female. It's about the degree of maleness and femaleness. And we showed very clearly that that continuum indeed exists, so that you can have more male, and that trait of femaleness or maleness is related to other things in the same way in both males and females.
Right.
Right?
Yeah,
so that's very important to keep in mind, that there is a continuum. And the second point, you described all this as restricted to prenatal period. Our research shows that something like that organizational effect, that long-lasting effect, may also happen during puberty, right? And so whatever is influencing, again, pubertal levels of hormones may again have a long-term sort of programming effect on our degree, maybe, of maleness and femaleness.
Fascinating. This is so fascinating because, without getting into the whole public culture thing, this has always interested me. And the idea that the level of maleness or femaleness is, I get it now. Just because your genitalia is one way, the brain can be something completely different. And also the features. I mean, now we're talking about features. We're talking about different aspects of the human body being influenced to one degree or the other.
Right.
But the other thing that I can't stop thinking about is the environment's role in all of this today, because we have, we're not just talking about DHEA and estradiol and testosterone. We're talking about xenoandrogens, xenoestrogens, things like phthalates, which we know block the androgen receptor from activation, being introduced into the fetus, causing, now we're talking about variables that are that we can't even account for, because these synthetic actors are affecting children today now.
Yeah, absolutely. But we need to go beyond the chemicals, right? So you just had, your previous guest was talking about obesity and type 2 diabetes. And as I was listening in, obviously obesity is related again to sex hormones, right? We know that fat tissue has aromatase that converts testosterone to estrogens. So, of course, the degree of obesity during adolescence may be influencing the level of sex hormones in this way, right? So it's not only the chemicals that come from the outside; it's also the chemicals that we are generating in our own tissue. Yeah. And then the other thing is, you touched on that. We are talking about, at least, here in Canada, we are very careful. Our funding agencies are very careful about distinguishing sex as a biological concept and gender as a sociocultural concept. And of course, the two are related. And one thing that we are very interested in is how the sociocultural milieu is actually, and therefore gender, is influencing the biological sex. I'll give you an example. The sociocultural milieu may be simply how stereotypically people in my neighborhood think about roles, gender roles. But in fact, they think, you can imagine there is a neighborhood where everyone thinks that firemen can be only men and nurses can be only women. Right. And then you can have a very different society or a group of people who think, well, it can be both. Now, that may influence, in fact, again, our body. That the concepts, the sociocultural environment may have an impact on the biology, but that's an open question that we'd like to pursue as well. So environment in many different ways.
I think the anthropology professor, Dr. Daniel Lieberman at Harvard, would agree with you, because he came on my show once. We talked about his book, The Story of the Human Body. And he said culture affects evolution more than anything else, because culture drives selection. Women are attracted to certain things during different periods of time that are culturally acceptable, and they mate with men that have those attributes to have children that have those attributes. So as culture changes, the offspring changes, and culture has the largest effect on evolution than anything else. I mean, famine obviously could kill a lot of people, but it won't necessarily influence the type of humans that we're producing 1,000 years from now. So it's fascinating. Right. It's very fascinating. So let's talk back about your study. So did you discover any specific susceptibilities later on in life to young boys who had lower testosterone levels during puberty?
We didn't go that far. Well, all I can tell you is, based on what we found, we think that one of the consequences of the combination of low and high testosterone, low in puberty, high at any particular moment in adult life, might be that you are actually more attuned to extracting information from the eyes. Now, this is very important. We know that as I mentioned at the very beginning, face is important. Yes. But eyes are super important. Why? Because in fact, for example, if you are looking at a face that is angry or fearful, you would not be able to see that unless you look into the eyes of that person. Mm-hmm. There is a beautiful study by people from Caltech, Ralph Adolphs, who studied a patient who had lesions in the amygdala, both on the left and right side of the brain. Mm-hmm. And that patient, when they showed him a fearful expression, he could not say. He could not recognize fear. But then they looked at where he was looking on the face, and that patient avoided the eyes. So they asked him, okay, please, next time, look into the eyes. And the patient was fine. He said, oh yeah, that's a fearful face, right? So that tells you that, of course, looking into the eyes is super important in the context of emotions, recognizing emotions. But also my student, the first author on this paper, Jite Liao, is from southern China. And I accepted her to our graduate program because she was studying monkeys in the wild. And once she described to me that when she was, out there, she was sitting next to a monkey, wild monkey, and she noticed that the monkey is looking in a certain direction. So she was paying attention to the eyes of the monkey. And it was good she did, because when she looked in the same direction, she saw a big snake, right? So the joint attention is allowing us to get into other people's head. We now know what that person is interested in.
Fascinating.
Right? Or imagine you are in a group of adolescent boys and girls. Obviously, you want to know who's looking at whom, right? And that helps you with, again, the social interactions, with mate selection, etc., etc. So eyes are important, and I think that what we showed in this paper is that testosterone is influencing how, during puberty, how we are going to look into the eyes later in life. And that may be a big advantage.
So from a social, I'm sorry. So, well, I was going to say, from a social standpoint, looking into one's eyes can seem confrontational to some people. I mean, I've talked to people who would not look. They would look at me in my eyes, but then dart, and they didn't want to look at me too long. So that to some people, looking in the eyes, because we also know somewhere deep in our evolutionary mind that you can attract harm if you look an animal in their eyes. Like I hunt, and
Right.
you can actually get very close to a bear or a deer if you don't look at them. If you look down at the ground, they know that you're not engaging them. Now with a bear, if you look a bear in the eyes, he's going to become vicious, because if you're looking him in the eyes, he thinks that you're going to attack. So could it also predict those people who are less confrontational? Is it because they had lower or they had higher testosterone during puberty, so that the higher testosterone later in life doesn't elicit that desire to confront?
Yeah, I don't know, but in fact, in our study, it was the other way around. That the boys who had high testosterone during puberty, the testosterone at the time when we were studying them as young adults, had the opposite effect. A little bit like what you're saying, that the higher the testosterone, less likely they engage the brain regions that are telling us that they might not have been looking into the eyes. So, you're absolutely right. I'm reminded of a study in roosters, puberty in roosters. And what they measured simply was, that was in semi-wild, that how far apart they sit on a tree when they go to bed, right, at night. And before puberty, let's say they would sit, 2 feet from each other. And as testosterone kicked in, the distance increased. So they would sit much further apart from each other, right? So there is that aggressive, competitive element in there, right? The dominance element in there. But it's a fine line, right?
This is fascinating. There's nuances that we just ignore, that now you're actually showing some correlation between sex hormone levels at puberty and then later on in life. That's fascinating to me, because from an evolutionary perspective, that means that there's a whole lot of other stuff behind it and why this happens this way.
Yeah, and I wish we had all the answers, but that's the fun part about science. You are discovering new things every day if you are lucky.
Are we promoting anything for you today? Any upcoming lectures, books, websites, anything like that?
No promotion.
Are you working on a new study now? Are you working towards some new research right now?
Yeah, we are looking into very much into in fact the same data set with my student Jitye, looking at the stability of that system, whether in fact those who have a very stable network that of brain regions that respond to faces are or not at higher risk of psychopathology. And so she is working along those lines, and we'll see whether the testosterone will be part of that picture or not. And then the other thing that we are doing with another student or postdoc in my lab is really continuing with his work on sex as a continuum. And so there we are taking those ideas to large numbers of individuals, thousands, tens of thousands, and trying to understand both the genetics of it, but eventually also the sociocultural dimension. Can't hear you. No, cannot hear you, sorry. I don't know what happened.
Test. Nothing?
Oh, got it.
Okay. Last thing I want to comment, and then we'll pull the plug on the interview. There's an interesting subset of the population that you should start thinking about, and that is bodybuilders. So as a former power lifter and a user of anabolic steroids, we know that there are some men, when using supraphysiological levels of testosterone or one of its derivatives, do tend to become more violent, let's say. And then there are others who it doesn't affect them that way at all. I have used as much as 3,000 milligrams a week of injectable anabolic steroids and some orals. And I have never been someone who became hyper angry or fly off the hand. But there are guys who do. It would be fascinating to find out where their testosterone levels were during puberty and their propensity to act a certain way once they were using superphysiological levels of testosterone. There's millions and millions of men out there at any given time who are using these drugs. So it would be fascinating.
Well, you're right on. And in fact, I am engaged in this kind of research with my colleagues in Norway. So we are looking at the brains of anabolic steroid users. Unfortunately, I don't think we'll be able to go back, of course, and get their testosterone from the time of puberty, but we may find some ways around it. It's a good idea, and we'll look into it.
I want to thank you for being on the show today. This is fascinating. I hope you'll come back as soon as you have more research.
Thank you for having me. It was fun.
Take care. Take care. All right, so that's it for today. We have shows the rest of the week. Hopefully people can tune in live. If you can't, there's always the podcast. Feel free to press the share button. If you're watching us on Facebook, there is a little share button that you can click right now and share the show on your wall so people who are friends of yours, when they come along, can watch the replay of the show. The replay is available immediately after the live show. And then, of course, we publish the podcast tomorrow. And the podcast is available at all different podcast platforms, Google, Apple, Spotify, and so on and so forth. We ask you to always share the show whenever possible. And that's it for today. We'll see you tomorrow with more Superhuman Radio. Thank you for participating.